lot of people ask, how is it different taking care of a child on a call as opposed to adult? Is a child just a little adult? And the answer there is no. Their systems are different. Assessing them as a patient is different. Vital signs are different. Treatments are different.
Whereas you or I would start having our pulse rate go up, we'd start complaining about not feeling well. Same scenario with a kid, they're fine, they're boom, 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 and then all of a sudden they drop. And when they drop precipitously.
How do you get a history? How do you get what's going on out of an 18-month-old who can't talk, who can't describe symptoms? You have to use parents, use diagnostic tools, use your exam, other things that you can see on the outside to try and figure out what's going on with them.
10% of the total patient load that you see in a year will probably be between the ages of birth and maybe 13, 14 years old. And then 10% of those will be what we consider to be sick or critical kids. So for some people, you might be talking 0 to 1 critical kid a year.
We know those are what we call low-frequency, high-risk patients. We don't see them very often because kids generally aren't as sick as adults are.
One of the problems with pediatrics is that it's really not something that we deal with a lot. Consequently, we have to continually train and practice on it.
You really should be capitalizing on practicing those skills that you do very, very infrequently, that when you do have to do them, makes a huge difference.
What do I think when I go on a call for a kid is that everybody's going to be a little more hyped up. Everybody's going to be a little more nervous. I think in general, everybody feels a little bit more for a kid.
I've been doing it for 30 years and still would not say I'm proficient.
Probably the biggest thing that's really making a sweeping change in healthcare is medication errors and what we call a culture of safety. Almost all the interventions that we do for pediatrics are weight-based. So it's math in a very chaotic situation. We don't randomly pull up medication or calculate things in your head. We always look it up.
There are tools out there that allow EMS providers to make more rapid decisions in terms of medications, dosages, and those kinds of things.
You're using different meds and concentrations that you're not really used to, so everybody's a little nervous, and you've got to deal with the parents, and so the dynamic's very different.
Probably the other largest difference between treating pediatrics and adults is the necessity to involve the family in the decision-making process in what we call family-centered care. Their primary source of patient history and information, and being able to rely on that information when the patients aren't able to speak on their own behalf. And they obviously know their children better than anybody else on the planet.
To see these beautiful little people when they're young and be able to keep them healthy and give them a good start to life. I mean, I think that's one of the highest callings you can have in medicine. I don't think it gets better than that.
So a few years back, I had a pediatric person, a 6-year-old little girl, whose brother was helping her do tricks on her bicycle. So she was standing on the seat, holding onto the handlebars, riding. She fell off and fractured her trachea. So her windpipe was essentially crushed. I know for a fact that without our intervention that day, she wouldn't have made it. We made a huge difference that day. We were able to keep Mom calm. The whole call went pretty well, and she came back 2 weeks later and visited us at the station. Mom was happy. She was happy. So that's what makes it all worthwhile. You get a couple of those in 27 years and you're okay.